Hello, my name is Anna Grimsrud and I'm a doctoral student at the University of Cape Town. Today I'm going to be talking about ART adherence clubs and circular migration, specifically utilizing 4-month versus 2 months of ARV refills, and this is the results from a collaborative analysis. As you may know, we have seen the rapid scale-up of antiretroviral therapy over the past decade, particularly in resource-limited settings. As this graph shows, the majority of people accessing ART are in Africa, and the shape of this curve is roughly the same to the South African scale-up story, where we now have around 2 million South Africans on ART. In South Africa, there's a long history of migrant labor, particularly people moving from rural to more urban areas in search of employment. In the Western Cape, where this research took place, there's a frequent migration pattern with the Eastern Cape. At any time, 1 million people from the Eastern Cape are residing in the Western Cape. As a result of this circular migration, many people travel home to their home province during the holiday period between December and January at the end of the year. And this circular pattern presents a specific challenge to providing uninterrupted ART. We also need to account for the fact that many patients end up staying home for longer than they originally anticipated. The research today came from 2 clinics in population-dense, high-prevalence and formal areas outside of Cape Town. The clinics in Gugulethu and Khayelitsha are located in communities where the majority of residents are of low socioeconomic status, and the antenatal HIV prevalence is upwards of 30%. In these 2 clinics, the Adherence Club model of care has been implemented. This is a model of care for stable patients designed to benefit both the patients as well as to benefit the overburdened healthcare facility in an effort to ensure and improve long-term retention and care. In order to be eligible for an adherence club, a patient needs to be defined as stable. Now, a stable patient fits our criteria if they've been on treatment for at least 1 year, have 2 consecutive suppressed viral loads, a CD4 count greater than 200, and they don't have another chronic condition that requires more frequent clinical consultations. A group of these stable patients, 30 of them, form one club that meets every 8 weeks or 2 months, either at a health facility or in a community venue. At the club session, a lay counselor provides group support, and then each patient is weighed, screened for symptoms, and given pre-packaged ART. Bloods are drawn annually, and patients also see a clinician once a year. Last year, as the end of the year approached, we realized that clubs that were scheduled to meet between mid-December and mid-January would likely have low attendance due to the holiday migration patterns. Therefore, at the 2 sites, clubs that were scheduled to meet during this time were given 4 months of ART at their October-November visit so that they would have a continuous ART supply until mid-January. We then compared the outcomes of these patients, the ones who received 4 months of ART, to those who received the normal 2-month supply. We looked at the proportion of patients defaulting from the club, as well as the proportion of patients that experienced virologic failure. The results were very promising. There was no difference in the percentage of patients defaulting from clubs. Out of almost 2,000 patients, roughly 4% defaulted from the club, but there was no difference between those who received 4 months and those who received 2 months of ART. Similarly, we saw promising results in regards to virologic failure. As you can see, there was about 1,400 patients who had bloods drawn in the beginning of 2013, and less than 4% of these patients had a viral load of above 400, which was our definition of failure. If you look at the numbers for the 4-month and the 2-month group, you'll see that there was no meaningful difference between these 2 groups. As a result, and in collaboration with the government, we saw that in 2013, all club patients received 4 months of ART. This was useful because club patients now meet only 5 times a year instead of 6, and we have no clubs meeting in December or January. It's a great example of how operational research can influence practice. One of the challenges was bending the rules. The dispensation policy in South Africa is that a maximum of 3 months of ART can be dispensed at a time. To get around this, we say that patients would receive 2 2-month ART packs. So we need to look at changing this policy to reflect the needs of the ART program going forward. It was also an exercise in letting go. As we transition to a more patient-centered approach, we need to trust our patients with increased self-management to make it easier for them to stay on treatment. We also need to start talking to our patients about traveling and their traveling plans so that they can come up with solutions to ensure continuous, uninterrupted supply of art. The results have led us to ask, what is the optimal visit frequency for stable ART patients? We only evaluated the impact of a single 4-month art dispensation, but what about changing the club's model so patients met every 3, 4, or even 6 months? What really makes sense for patients and for services? Going forward, I'd like to leave you with 3 main points. The first is that clubs can successfully manage stable patients, and this is done by lay counselors. The role of this cadre of staff is increasingly recognized, and we need to formalize their position within the healthcare system and within these ART models of care. We're also going to see more and more patients eligible to initiate art, and we need to balance this with ensuring long-term retention. So point 2 is that we need out-of-the-box, radical thinking for new models of care to face these unique challenges, especially in art programs where there's large numbers and resource limits. The status quo is not going to be sufficient. Finally, the Adherence Club model is just one model of care. It is recognized that we need a comprehensive package of innovative models that can be adapted to the context if we're going to manage these large-scale ART programs. And operational research has a lot more it can contribute in this regard. In conclusion, I would like to thank the collaborators of this research, those at the University of Cape Town, Desmond Tutu HIV Foundation, and MSF South Africa. I'd also like to thank my funders. I look forward to discussing models of care and the frequency of ART refills with all of you going forward. I can be contacted at my email address, agrimsrud@gmail.com. Thanks very much for listening.